So panelists and participants, good evening.
Good evening.
Yeah, we should be able to start in 1 or 2 minutes, but I welcome everyone to this webinar. This is one of the series of weekly webinars we've had. So we are looking at a series. We've come from step 1 to step 7 of quality improvement. We've come from preparedness from departments to responding. Now we are going to the last phase of the training, which is case management and special consideration today. And in addition, we look at the quality improvement establishment process in terms of how do you start as a facility. And out of that, going forward, then from tomorrow, we'll go into experience sharing, and we will be able to welcome everyone so that we see how are we responding, how are we prepared across the country. So with us, we have panelists. I begin with Emily Omari, and then Maureen Kinoti, and Teresia Mumo. So today, ladies are leading, and we know you people, you are capable up to the task. So most welcome. Ken will be joining us shortly. While we do not want to take time, want to start so that we have enough time to go through. It is 6:01, so we will start straight away. So participants, you are most welcome in today's webinar. You've had a topic and the discussion that we'll go into. So I will request you to please engage using the chat box. We'll be able to answer questions after every presentation and also at the end, but also the panelists can be able to answer the questions real time, meaning quickly replying on the chat box to your questions. So we'll take the next 1 hour to begin the presentation. And today, we will start with us. We will start with Maureen. Then after Maureen, we'll go to Teresia, and then Emily will conclude our presentation for today. So let's go in that order. I will ask Emily, introduce yourself, Teresia, and then Maureen, who will be able to start us off. Emily.
Thank you, Walter. Good evening, viewers. Good evening, participants. My name is Emily. Emily is a registered nurse who is a quality assurance officer at PCA Kikuyu Hospital. And welcome in this series of managing COVID. Thank you.
Yeah, I'll be sharing the slides. So, Teresia.
Yes, Walter. Good evening. My name is Teresia Mumo. I serve as a regional manager working with Farm Access Foundation. I serve to implement a program called Safe Care that we work with facilities, both public and private facilities, to help them identify their quality gaps and see how we can be able to seal them and certify them in terms of quality. And I'm a trainer of trainers for COVID-19. And thank you so much for having me today, Walter. Thank you.
Okay, are you able to see my screen sharing?
Not yet.
Okay, I'll be doing that straight away. So let me go to the first slide. So start us off, Maureen.
Good evening, everyone. It's nice to see all of you. Today's topic of case management is very interesting of COVID-19, and we don't pretend to be the experts here. As you've heard, my name is Maureen Kinoti. I'm a clinician. I'm also a health systems manager, part of the Health Systems Management Association, and I'm the chair of a technical working group in the association that deals with innovation and research. However, today, in my normal days, I work at the African Nazarene University, where I'm in charge of health services. Today, we are straight away going to talk about case management, and I'll start us off with the basics. I also know that we have a majority of clinical health workers here, and I know your experiences will matter a lot. So at some point, if we have time, we will appreciate experience sharing through the chats. and through the Q&As. So how do we begin this care pathway? A person enters this COVID-19 care pathway the minute they are screened, and based on the standardized case definition, including assessment of any symptoms, they meet the criteria of a suspected case. So what happens after that? Next. Kibet, next slide. So we categorize these care pathway cases. We have suspected cases who you may refer to as a person who is under investigation. In our setting, this could be contacts of people who have come into contact with COVID positive cases. Once this person is a suspected case, they are categorized as entering the care pathway. Probable cases are suspected cases who we have done tests, but the tests are either inconclusive. And remember, viral tests can behave like this, as some of you may have seen in clinical settings, or even the test is not available, but they meet each criteria of our case definition. So these are probable cases. Confirmed cases, that is clear. There are people who the lab has confirmed that they have COVID-19 using the PCR test. So next slide. Key points before we go on. These suspected, probable, or confirmed are isolated immediately, and they are cohorted separately. You do not mix confirmed with probable and suspected. There are various ways of isolation and cohorting that keep changing depending on the circumstances in the country. Kenya right now has been taken to quarantine centers, others to isolation centers, others to hospitals. Right now, we are going into a phase of home-based care. So it depends on the circumstances of the country. There are considerations that you have to make for co-infections and chronic diseases, as we'll see on later, and every suspected case must be confirmed. And they remain in that care pathway until they are proved negative. Next slide. So what do? We are repeating this. First of all, make sure you're safe. Notify, confirm the case, document. There's a whole range of MOH documentation you must do when you have a suspected case. That even includes that for contact tracing and follow-up, risk communication to the people who are working around you and the people who are around the patient or the case, and of course, data management. Next. So what do you do when you get a suspected case? You've all undergone this or you've all come across this. Give them a mask. Don your PPEs the correct way, as Teresia taught us last Friday. Isolate the patient in a well-ventilated single room that meets that criteria we've been given, and immediately notify the surveillance officer of our hospitals, our facilities, and this officer is the one who notifies the Ministry of Health at county or national level, depending on who is nearest. Then there are those requisite outbreak investigation forms that should be filled. Next. Next slide. So how is the diagnosis made? Of course, clinical presentation, epidemiological link, though right now when we are in the phase of community transmission, we are no longer asking about history of travel or contact with someone. It could be you don't know who you came in contact with. However, we know that there are other epidemiological linkages like high risk populations like truck drivers and places of where people have been or where they live. So do the appropriate sampling. We did the lab sometimes, I think 2 weeks ago, we did the lab procedures. It could be an oropharyngeal, nasopharyngeal, or a serum sample. Next. So once this has been confirmed, you fill, of course, the case investigation form, and it should be completed for every case. I've already talked about this, but I'm emphasizing because this is how we maintain data and we notify the necessary people that we have a suspected case. Next. So at the screening and triage point, especially in hospitals, A&Es, casualties, all patients with subacute respiratory infections at first point of contact in the healthcare system must be suspected as possible SARS-CoV-2. Then you use the case definition to describe them. This way, you're able to recognize early any suspected cases and confirm or release. And if there are severe cases, for example, someone is in respiratory distress at this point in time, you will have to suspect for SARS-CoV-2 so that you can initiate treatment for severity very quickly. And of course, we will always refer to our current case definitions. And where it is a severe case, you start emergency treatment immediately before you even wait for confirmation of the results. Next. So what are the benefits when you identify early? You're able to give supportive care at the optimum point. You're able to rapidly refer and admit at the right place. For those who have comorbidities or are above the age of 60, we may even admit them for close monitoring because in the event that they get severe, we know our ambulance services with curfews and all that, it is very, very difficult to get to hospital quickly. So you will admit them not because they're very, very sick, but because they're older or they have other comorbidities like asthma that we'll see later, diabetes and hypertension. For people with mild illness, sometimes hospitalization may not be required. We are currently doing it. However, we are moving probably to home-based care. The only time you may not do that is that if you're concerned, they will rapidly deteriorate or they are unable to come to the hospital quickly, or even their home conditions make them a risk to the rest of the community. Next. So we have various clinical syndromes that are associated with COVID-19. We have the mild illness. Initially, we were talking about a higher percentage than this. This percentage has gone down to 40% as per last week from the WHO. That these are people with non-specific symptoms. They'll have the tiredness, the cough, the fever, the loss of appetite, the weakness, muscle pains, general upper respiratory or lower respiratory symptoms, mild ones. They may have a headache. Diarrhea, nausea, and vomiting, as we now know, is a common presenting symptom. Elderly and immunosuppressed patients may have other symptoms which are not typical of COVID, but could indicate that they have underlying conditions. And women who are pregnant, their symptoms may overlap with those of COVID-19. This includes the vomiting and the anorexia. Next. What do you do with these cases? No need for hospital interventions. Isolation is necessary once you've confirmed so that you contain transmission. And again, it depends on what we are doing as a country, which we are all aware of. However, despite indications saying you do not hospitalize, it is very important that IPC is adhered to. We have done a lot of IPC for the last almost 1 month with Teresia, because you want to contain and mitigate transmission. So it doesn't matter whether they're mild or severe, IPC protocols must be followed. And this can be done either in hospital, if there are only a few sporadic cases or small clusters, or even in settings where people are setting up centers in schools or in stadiums. We've seen beds being put in stadiums in such kind of settings. Give them symptomatic treatments like Panadol, like, just to manage the symptoms. Cough syrups, they are being put on multivitamins to support the immunity, good nutrition, just supportive treatments. Most importantly, counsel them about the signs and symptoms of complications. Should they develop this, then they should seek urgent care, especially if they are not in the formal healthcare system. For example, when we start doing home-based care, this will need to understand what is the complication so that they can seek care urgently. Next. So what are some of the clinical syndromes? Of course, pneumonia. Pneumonia doesn't change much. We all know, or we need to remember how to diagnose pneumonia. For adults, if there's no sign of pneumonia, and we all know the signs of pneumonia, there could be chest pain, there could be fever, there could be cough, or even without. You may do other investigations to confirm. If in an adult, if they don't have signs of severity, for example, they don't have difficulties in breathing, that is dyspnea, if their oxygen saturation levels are normal, you may not need to give any oxygen. Diagnosing pneumonia in a child is is very clinical before even you do any investigations. You have to have cough or difficulty in breathing. The child has to have a fast breathing. And remember the cutoffs. Above less than 2 months, more than or equal to 60, 2 to 11 months, more than or equal to 50. A child above 1 year, more than or equal to 40. If they have no severe pneumonia, again, no oxygen. You just manage just like the other patients. However, signs of severe pneumonia, as we see in the next slide, will need now other levels of management. Those are the criteria. At this point, I must indicate that as a health facility in this era, every health facility, I think one of the things the A&E or the casualty should have is a pulse oximeter. Why this is important, and now they are readily available and affordable, because oxygen saturation is a good indicator of severity, such that the normal is of course considered between 94 and 100% oxygen saturation. So any patient who has increased respiratory rate and oxygen saturation of less than 93% may require oxygenation. For a child, less than 90% with severe respiratory distress that we see in children as chesting, growing, grunting, or they have the other general danger signs. For those who've done IMCI, you know what I'm talking about. Unconsciousness, convulsions, lethargy, vomiting, inability to eat, all those danger signs still apply. Now, this we categorize as severe pneumonia. Pulse oximeters are an easy way to segregate those who are in the danger zones and require advanced management. Next. So about 15% of all cases may require early supportive therapy, and these are the severe ones. And they will require oxygen therapy, which you must be very careful when administering, because if oxygen is administered badly, it will pose a risk for you as a health worker, because there could be a lot of aerosolization of from whatever the patient is breathing out. Remember, they're in distress, so they're having heavy breathing. So if you do not oxygenate properly with the right things, then you're putting your health workers at risk. So you start at 5 liters per minute and adjust to reach the target. Children with all the danger signs should receive oxygen therapy during resuscitation up to the level where their saturation is above or equal to 94%. Otherwise, the general target is 90%. As I said earlier, pulse oximeters are important here. We need to be careful. Next, it's okay. Just move next. Be careful about fluid management in patients, especially those with respiratory distress, where there's no evidence of shock. Because if you aggressively give fluids, you will dilute the oxygen you're giving. So you'll worsen the oxygenation or the oxygen saturation in the blood. Then treatment of acute co-infections. Current guidelines are telling us that for suspected or confirmed moderate COVID-19, you only give antibiotics if you have high clinical suspicion or have confirmed bacterial infection. We have the tendency of giving antibiotics to each and every patient we get with respiratory disorders. Now we are being given a word of caution about that. Another word of caution is on systemic corticosteroids, because they will suppress the viral detection. The disease will continue and they could cause other problems, including, you know, all the side effects we know of systemic corticosteroids. Next. Kibet. Kibet, your slide has so as he's trying to get the slides in order, Kibet, the slides have gone off. You've gone to the last one, go back up. Okay, go down. Yes, there. So we were talking about oxygen therapy. As you're doing oxygen therapy, monitor the vital signs so that you're able to see any changes of respiratory failure or signs of sepsis, and you're able to respond immediately. This is sometimes a matter of minutes, so that if you miss key vital signs, you will probably lose the patient or you'll get complications. The lab testing and the ECG should be done concurrently on admission, as you're doing all the other resuscitatory measures for severe COVID-19. And of course, you have to monitor for things like shock, cardiac injuries, kidney injuries, and liver injuries. This is especially important for patients who are elderly or with comorbidities. After you resuscitate and stabilize pregnant patients, again, remember the child. fetal well-being must be monitored. Understand all the other comorbidities the patient may be having so that the management will be balanced. It's not just for COVID or the respiratory distress, but it's for everything that the patient is coming with. Then determine what other therapies this patient is having that must be continued. Drug interactions, be very careful with this. Some are on systemic corticosteroid, inhaled steroids, and those kind of things. So which therapies can be stopped temporarily and which ones should be continued concurrently? And then interactions, as I said. Next. Next, Kibet. So ARDS in COVID-19 is critical. When a patient who is in respiratory distress fails to respond to standard oxygen therapy, decide on intubation, and this should be done by a qualified person. The person must be highly qualified to intubate. There's a lot of fibrosis that may be happening in patients with COVID-19, and this must be done very carefully. Mechanical ventilation using lower volumes and lower respiratory pressures may be considered. For adults and children, this can be done when they are prone. But for pregnant women, they must be in the lateral decubitus position. And as usual, conservative fluid management, especially where you're having severity and acute respiratory distress. So what are the key changes? I would urge all of you to go to the WHO website and download a very big document, I think about 60 pages, that was released last week on case management. Case management is changing from experience, what we're experiencing and how we change, and hopefully we are able to customize to our situation. So what has changed? It has said that pharmacological prophylaxis, such as use of heparin, there was some talk in social media about anticoagulants. This has now been formalized, that this should be considered to prevent venous thromboembolism, where this person has no contraindication to blood thinning products. For those who have contraindications to blood thinning products, then mechanical prophylaxis can be considered. And this is using pneumatic pressure that is intermittent because they may not be able to take the heparins and all the other derivatives of anticoagulants. Antivirals, immunomodulators, and any other therapy we have heard of that is listed should not be administered as routine treatment or as a prevention for COVID-19 outside the context of clinical trials. Formal clinical trials are going on all over the place and they're using various therapies. These have to be formalized as clinical trials for this kind of management to be considered as safe and acceptable. At that point in time, I'll talk about how do the patients get out of the care pathway. So we discontinue transmission-based precautions, including isolation and release from the COVID-19 pathway if, for patients who had symptoms, 10 days after the symptoms onset, plus at least 3 days without symptoms. This includes fever and any other respiratory symptoms they may have had. And this is in addition to the laboratory 2 tests that have tested negative. And for asymptomatic patients, those ones with no symptoms at all, 10 days after they have tested positive, then they can be released depending on the test results that have been later done. WHO is a bit silent on the test results, I guess, because some people retain antibodies in their systems. But I know currently we are retaining them until they test 2 tests negative. But please note, releasing a patient from the COVID-19 care pathway does not mean you've released them from the facility. Remember, if you have comorbidities or any other complications, you need to manage everything so that the patient is completely healed from everything that brought them in before you release them from the facility. So they can be released from the COVID-19 pathway to a general ward or to another part of the hospital, even in the same place, to continue other treatments. So with that, I think I'll conclude, and thank you very much. Questions are welcome. Thank you.
Thank you, Maureen. That has been very, very well put. Participants, so together also today, we've been joined by our chief moderator, Ken. You can say hi as we embark to the next presentation. Ken.
Hello and good afternoon, ladies and gentlemen. It's a pleasure to join you once again this evening. and karibuni sana. Thank you, Walter.
Thank you, Ken. Most welcome.
And rest of the
panelists, thank you. So what we are going to go next is the special consideration and circumstances under COVID. So that will be taken by Teresia. So Teresia, you can go ahead so that when we come towards the end, then we'll be able to combine the questions.
Thank you, Walter. Let's go to the next slide. Yeah, so this is just a sum up of the pathway that Maureen has been talking about. What I think your screen is off.
Wow, okay, sorry.
And just to remind ourselves that we might be having some air around us that maybe the curfew and all these other measures might be lifted up. But I think it's a really heated discussion on when to open up and why to open up this time when our cases are still going up. I think as we talk, we have 74 deaths, maybe below what was projected by WHO and even our country teams, but it's still worrying that we have deaths up to 74 that are being caused by COVID, among other comorbidities. And this is between March and now. And what is coming from the ministry is that most of the patients are in isolation facilities in Nairobi and Mombasa, and facilities have exhausted their capacity. That is a bit worrying coming from the ministry, because sometimes ministry talks from a high level, but when you go sometimes to the facilities, things can be really thick. So when you hear facilities have exhausted their capacity, then it hits back to us that we need to get prepared as healthcare providers from wherever we are to be able to know how to start care management of these patients. As much as now the pathway starts by even us calling the county rapid response teams if you get a case, but there is what you need to be able to put in place for that patient before they are transferred to the next patient, to the next maybe treatment center or quarantine site. So we need to be able to know the care pathway, and the care pathway will start from just the way Maureen said. From if the clinician gets concerned over COVID-19, if they suspect that somebody could be having COVID-19, then they contact the national call center or the county response team, and then they're the ones who will assess whether the patient actually fits to be a COVID-19 suspect case. And then if the patient is not a suspect, they are reassured and given measures to be able to carry out, and also go into the normal pathway to be able to receive care for other morbidities they're looking for, they're having. And then if there are symptoms, then they're taken care of. Next slide. So this is almost the same way, but this one is just to emphasize almost the last two columns. One is talking of mild or low risk moderate cases, and bottom there we have high risk or moderate or severe or critical cases. So just to say that even in the treatment sites, then we'll have to segregate the patients to the one who have mild or low risk disease, and then they'll be put in a treatment site, but the ones who have high risk or severe disease, they'll be put in isolation in intensive care units. And then, of course, Maureen has finished by talking of release from the pathway. Next slide. So we have special considerations in COVID-19, and these are patients who are old, the elderly, we have pregnant women, we have diabetes, and we have also have patients who have hypertension, and also patients who are having cancer. So those are special considerations that you need to put in place when you're assessing your patients. So in talking about older persons, we know old age comes with other comorbidities. And this, of course, now raises the risk factor for these people in terms of COVID-19. So we want to underline and say that older people have the same rights to receive high quality healthcare, including ICU care. So even when it comes to, in terms of ethics between an old person and a young person who is to be given a ventilator, remember that all of them have the same rights to receive high quality healthcare. Okay, so we need to be able to provide person-centered assessment, including routine history taking and all persons' life values, priorities, preferences. So we need to look at that person as a whole and take a whole thorough history. We need multidisciplinary collaboration because we are saying they also have other comorbidities. They could be having arthritis, hypertension, diabetes itself. They could even be having cancer. They could also be having maybe having had a bout of TB. Okay, so we need to be able to include also other disciplinary people around us. And this could be physicians, nurses, pharmacists, nutritionists. Those are people who are important for care of the elderly. So some of the physiological changes that they go through make their immune system not to be able to respond well, and they go into malnutrition. They also have a decline in terms of cognitive ability. They could be having depressive symptoms. The other day, I listened to the CS of Health saying that COVID is also presenting with some depressive symptoms. So now we are talking of the elderly people even having depressive symptoms themselves. Okay, so you need to be able to take thorough history. So you need to be able to remove inappropriate medications to prevent adverse drug events. Remember that we are saying that they also have in other comorbidities. They are prone to polypharmacy, where we have multiple drugs being taken by the same patient. And when you talk of polypharmacy, we get to a point where maybe they're taking more than 5 drugs in a day to treat different ailments. So we need to be able to remove and align all medications so that you don't have adverse drug reactions. Then involve caregivers and family members so that you make the best decision and so that they can also be in line with what you're putting in place as a management for these people. Next slide. So just to underline, remember that COVID-19 causes severe disease in patients with comorbidities. So it's important to manage the existing comorbidity, and also remember that you also being careful to avoid polypharmacy. Okay, then consider that differential diagnosis based on clinical symptoms and medical history. COVID-19 could be presenting as just a typical pneumonia. So you need to be able to make your differential diagnosis and treat appropriately. And don't forget, psychosocial support is critical for all patients, the elderly to the young, to the pregnant, and to the other ones who have other comorbidities. Next slide. So let's talk about the pregnant women. There's limited data on clinical features and perinatal outcomes for COVID-19 during pregnancy and puerperium. There is no evidence of vertical transmission from mother to child for COVID-19. So at least there we can say that babies are lucky as at now. We also have very few cases of babies who have been infected, but even the ones who have been infected, they've shown mild disease. Okay, so you need to manage women, at least with woman-centered, respectful, skilled care, including obstetric, fetal medicine, neonatal care, and all other care that we need to be able to support these women as they wait for their baby, okay? And also to avoid neonatal complications. So let's talk a bit about non-communicable diseases, that is hypertension, and also a bit about diabetes. You need to be able to continue or modify previous medical therapy if you get a patient who has hypertension, okay? Antihypertensive drugs should not be routinely be stopped. Remember, some drugs act as, remember SARS-CoV-2, the coronavirus that's causing COVID-19, uses the SC2 receptor for entry into cells. That is angiotensin converting enzyme 2 receptor. Just a reminder that SCE is part of the renin-angiotensin system, which controls blood pressure. And this in terms of regulating the fluids in the body at the kidney level. And it acts just to convert the hormone angiotensin 1 to a vasoconstrictor angiotensin converting, angiotensin 2. Okay, if I've gotten that right. Okay, so that's the famous renin-angiotensin system. That's the RAS system. So if the SARS-CoV-2 then uses the SC2 receptor, then you're having drugs which are acting as the SC2, then we are saying that COVID-19 is showing to either exacerbate the condition for hypertension. Okay, it's worsening to some clients, and to some clients it's acting to reduce the effects of the drugs that are being given. Next slide. So for diabetes, we know among the diabetes, the most vulnerable among the diabetes clients will be the ones with uncontrolled diabetes mellitus, the ones with HbA1c reading of more than 7.6%. Okay, the ones with fluctuating sugars, the ones who are old, of 55 years and above, and others who have comorbidities like heart failure and hypertension. So those ones are most vulnerable. So in our facilities, we need to be able to get in touch with those patients, ensure that they have the right medication, ensure that they are controlling the blood sugars, ensuring that their treatment partners are actually following up on the treatment. And then we need to avoid admitting anyone with diabetes. Unnecessary admission for these patients is exposing them actually to more infections in the hospital and maybe to even COVID-19. And then we need to ensure that there's strict hygiene measures which are laid down, especially when it comes to wound care. Next slide. So just a reminder that coronavirus can survive up to 8 hours on fabric. Therefore, you need to be able to launder our scrubs so that in case there is any infection that has been, that is on our scrubs, then it does not now get transferred to our family members and to the next maybe clients that we are dealing with. Just a reminder again that we need to be able to decontaminate our surfaces with 0.5% chlorine-based solutions, and also even that includes also our instruments, our equipment that we're using, that is the stethoscopes, the blood pressure machines, glucometers, to prevent the spread of coronavirus. And then we need to be worried as clinicians that our desktops need to be sanitized as frequently as possible. And this should be automatically be after every other client, because you don't know what client you attended to transmit this infection to yourself and to the next line, or even to your co-workers. Next slide. Walter. Okay, so women during pregnancy, we've said that there is limited data on clinical presentation. Remember, we are dealing with a new virus, so we have limited clinical data. And we had said also there's no vertical transmission, but you need to be able to counsel women on danger signs at the ANC clinics. This could vary, and some of them will be decreased with fetal movements when there's bleeding or leaking of fluid from the vagina, blurry vision, severe headaches, dizziness, severe abdominal pain, convulsions, difficulty in breathing. So those are just some of the danger signs that you need to be to warn the pregnant women. But remember, bottom line, follow the ANC guidelines. That is what is laid down. Okay. Then you need to update birth preparedness, so that they know when and where to seek care in case they have any of the danger signs. Next slide. So ensure that you still following the ANC guidelines, and you need to standard case so that they're also not suspect, or they are not COVID positive, and they're still walking around with the pregnant women. And then follow the IPC guidelines. And then the mode of birth should be individualized. So there is no call for us to start having increased cesarean sections because somebody has COVID-19. It's not there. That WHO does not recommend any induction of labor. It should be on case-to-case basis. Okay, next slide. So something just to underline here is that delayed umbilical cord clamping, not earlier than 1 minute after birth, is recommended for improved maternal and infant health and nutrition. That has been really researched and talked about, that there's a lot of health benefit in terms of giving the newborn a high HB even at birth, and the iron improves generally in terms of their response, just building their immune response, okay? So this is not just something that is new for COVID-19. Then pregnant and recently pregnant women who have recovered from COVID-19 and have been released from the COVID-19 care pathway should be enabled and encouraged to receive routine antenatal, postnatal, or post-care abortion. So nothing different from the women once they recover if they've been sick, okay? So also women choices and rights to sexual reproductive health should also be adhered to, and they should be able to get access to these services without any restriction. And that includes to contraception. So there's nothing that is hindering us there. So we recommend that mothers with suspected or confirmed COVID-19 should be encouraged to initiate and continue breastfeeding. Remember that we say that for babies, even if the mother is positive, the benefits to the baby in terms of getting breast milk outweigh even the dangers of COVID-19. Remember that we say that babies are getting mild disease. So for them, then the nutrition in terms of breastfeeding outweighs the dangers of COVID-19. So they need to be able to continue breastfeeding, but ensure that the mother observes highest forms of high PC, that is ensure that she has a mask. There's a lot of hand washing, and there's a lot of movement or limiting movement or maybe visitors to the baby, so that we don't just unnecessarily expose that baby. Okay, so I think that should be it for me, Walter. In case there are any questions, then we'll be able to take them. Thank you.
Thank you very much, Teresia. Hello?
Yes.
Yes, Teresia, before we move to the next question or the next session, the CS had mentioned that we as a country are moving towards seeking treatment in our homes, like home-based care. The CS has mentioned that very soon we'll start to see home-based care. So how do we advise our participants that they are able and they are in a good scenario to be able to explain to the community that there is safe care currently in our health facilities, so there's no cause for alarm for pregnant mothers to seek antenatal services?
Thank you, Ken. The healthcare workers need to be able to come out and talk openly of the measures they have put in place to be able to safeguard clients from getting transmission from any client who is COVID-19 positive. So they need to be able to proactively talk about what they've put in place, the social distance, the hand washing, the IPC, the treatment that is being done there, and even just upholding the dignity of every client that comes in there. Okay, so clients need to be able to hear this and know that this is also what is happening. And even if that one mother comes to the facility, she needs to be able to see that she's being handled well and there is no possibility of being getting infections from the facility. Just to get a story that I had from Nyeri County is that initially we had a wave of clients actually running away from the facilities. But I think when the CS and the Ministry of Health came out and said that if you have existing comorbidities, that is the likes of hypertension, diabetes, if you're pregnant and you're elderly, then you are at higher risk of getting COVID-19 and the severe form of it. So you better come back to the facility and get the proper treatment, manage your comorbidity, manage whatever ailment you have before you even get COVID-19, which we hopefully hope that you don't get. So mine is just to say that facilities should be at the forefront. As much as the CS may say that you have put in measures in our hospitals, even the hospitals needs to be able to demonstrate and ensure that our facilities give clients that confidence that they are being taken care of well.
Thank you very much, Teresia. Okay.
Just to mention,
yes, go ahead.
Maybe we may be having few cases now, and we are lucky that whatever cases we are having are mild asymptomatic and even mild symptomatic cases. But God knows the future, and we might be able now to start working, doing home-based care. But in our situation, where social distancing, even in our homes, is actually non-existent, this might be tricky and should be able to call for high forms of restraint. And just somebody saying, I might not be able to practice this home-based care in my situation. But I think maybe there are Kenyans who should be able to practice this. So I think it's something that we need to see going forward. What will be the government be talking about? People might want to actually stay at home, maybe the ones with mild disease, but there is the danger of exposing your whole family again to the disease. Yes, Ken.
Thank you. There are several questions about the same. So let's take Emily Omari, that she will guide us on how to use quality improvement during COVID response, so that when we move to the home-based care, or when we move to the facilities, then what steps are we taking to improve the quality of services? Emily, kindly take us through the activities and the process at the facility, and we see whether we can make that awesome. Thank you. Welcome, Emily.
Thank you so much, Ken. Thank you, Maureen and Teresia, for the nice presentation. Thank you, participants. And after seeing the pathway and after seeing the special consideration, let's now talk about starting the improvement course in the health facility. Now, this is the actual implementation on the COVID-19 cases. So what are the steps that we need to put in place now, in this situation, in this status of COVID? So number one, we need to identify the COVID response team. That is the first step any facility must employ. If your facility you are representing doesn't have this, let's be the flag bearers. That is the first step. And this team should have been constituted back in March, but we are not so late. We can still do that. After creating the team will sit down and get the protocols. The protocols will majorly constitute of the clinical, these things that Maureen has talked about, and Teresia has been addressing the clinical protocols and the infection control protocols. If you've been with us from the last 1 week up to now, you've had a lot being talked about in terms of infection control. And today we have handled so much on clinical consideration. So those are the protocols the institution or the facility should put in place. It doesn't have to be a whole document of 6 pages, but it can be just a page showing a flowchart of what begins and what ends. After making the protocols, the next step is to communicate these protocols to all the relevant stakeholders. And you find in a facility, the clinician will have to work with the pharmacy technician, together with the nursing team, together with the biomedical engineers, communicate these protocols to the relevant stakeholders. And after getting them communicated and getting them trained, then now let's implement the protocol. While implementing the protocol, if you've been with us again from the last 1 week, you know how the steps of quality are being deployed. So during the implementation, we should always be having action after studying whether we are getting results or not. Next slide. So infection control prevention is the major thing when it comes to IPC. The main focus in the protocol will be able to enhance infection control so that the healthcare systems in that particular level does not get infected and ground the entire facility. The first thing we have to deploy in the health facility is IPC hand washing measures. We need to also ensure there is proper screening and maintaining social distances in our facilities. We need to have modalities of implementing social distance at our facilities. Then we need to recommend isolation practices. You find in these things, the ministry and the WHO has proper guidelines that we do not have to create. They are already there. We just have to tailor make them to fit our facility. Next slide. In managing a suspected case, this is the flow of the patient. When the patient gets at the gate, the main entrance of the facility, You have to get this thing. Does the patient have an acute respiratory infection of any degree? It doesn't have to be severe. If there is any degree, including at least one of the following, there is fever, there is shortness of breath or cough, or there is severe and acute respiratory infection requiring admission to a hospital with a clinical or radiological evidence. These are the things that should be captured at the entrance of the facility. Let's move. When you look at this flowchart, those things you've asked at the entrance of the facility, before you even ask that, we should have implemented all the IPC standard precautions, meaning before this patient or this relative comes to your person who is doing the screening, they should have hand washed, they should have sanitized. The next thing is screening. At the screening level, you take the history of fever, then the history of temperature. If there is a cough of any severity, mild or major, then if there is that cough, get further history. Has the person been exposed to a confirmed case? Or traveling right now is not so important because now there is community transmission. So has the person traveled from the case where we have major cases? For example, has the person come from Mombasa? Has the person come from Nairobi? Those are the new Chinas currently. If the person has done all that, then this is a case that is supposed to be put under investigations. You would not allow this patient to move onto the facility to freely move around. They need to be put under case investigation to get further history. Then if you confirm that this is true a suspected case, by checking on the tachypnea or there is hypoxia, the SpO2s are now below less than 93%, or the respiratory rate is more than 20, then this person is supposed to be put on a supplemental oxygen, or if there is no, at that level, that's the time you now take a swab. Look at the flow chart. If you do all these things, this patient will not mix with the others at all. Now, if the swab is positive, now you confirm the COVID case. What happens when you confirm the COVID case in a facility? There is the protocol of the national guideline on what to do. You either call the sub-county area after confirming for them to be admitted on the listed admitting centers. We know that it's not every facility that can admit a COVID positive case. We know the list of the positive COVID case handling facilities. So if the positive case has arrived in your facility with the results, refer them, properly contain them, and let them not move about. If the swab is negative, consider other causes of the history or the cases of the clinical presentation and manage this patient as the way you could have managed the others. If this thing is done at the entrance level, we will not have any person in the facility getting quarantined. What happens when you have a positive case in your facility? Before the patient is moved anywhere, remember, you will have put this case under investigation at the holding area. It's not called isolation, but holding area as you await for results. When you confirm that this patient is positive, this patient is put at the isolation area until they are properly transferred to the facility approved by the ministry where COVID cases are being managed. The other things that we need to have on managing this transmission is we need to put isolation measures in place. The area has to be properly aerated. You have to maintain social distance at all times. And anytime the patients are walking onto the facility, patients or staff, everybody should be under a mask. Screening is done to patients and relatives walking onto the facility, not patients alone. Let's move to the next slide. So in many facilities, you can realize like hand washing basins have been put in strategic areas near the entry points. And washing of hands is done when you get in and when you get out. That is one of the facilities that they are being guided that all health workers and patients must do hand washing at the entry level. That is at the entrance of the facility. Remember, whatever you are doing, you must communicate to your patients and to your visitors. Another thing that I forgot to mention at the flowchart is you have other patients in the inpatient. These patients must be protected from COVID. We will not allow all visitors to come in the way things were before COVID. So you have to inform them at the entrance what you are doing. Tell them it's only 2 or 5 or 6, whichever number you will have agreed in your facility, and remind them to wash hands over and over again. Because if you don't remind them, you'll keep on talking and informing them by word of mouth, and maybe it might increase the infection, especially if somebody does not have a mask. But when they read, they will understand. Next slide. Next slide. Okay, this is one of the facilities that has done a spacing of 1 feet apart. What you can do, because we initially had this kind of seating arrangement, you can label your seats, or you can separate if it is the kind of seats that can be separated. So you can see these seats, one has been labeled so that you don't sit all together. Again, you don't have to encourage people sitting inside the facility, especially if they're coming to visit someone. They should not be inside the facility, but outside at the gate area. Next. So on assessing the risk and containing the virus, I want to quote one of the WHO informal advisor member. He said all countries need to review their strategies now. So in countries, insert the name of your facility. We can't do things the way we used to do, like sitting, talking, having tea rooms and every single area, because even health workers, we are at risk. Our tea rooms have not been changed whatsoever. Our washrooms have not been changed whatsoever, and the door handles is another risk area. If you were with us the last entire week when Teresia was talking about infection control, these are things that we need to review consistently, and then ask the question, are we doing enough regularly and repeatedly to ensure that this COVID is contained? Thank you so very much. We can now address the questions in implementing these things in your facilities. Ken.
Thank you very much, Emily. And that was a very good presentation. There are questions here that have been sent to us. There is one that is being championed by Danvers. Let me see whether I got the name correct. Yeah. Onchiri. Yes, Danvers. Danvers Onchiri is asking, but before Danvers, Mildred. Mildred is asking, how workable is home-based care in Africa? How prepared are we for home-based care in Africa? And then we now talk about what Danvers Onchiri is asking. So I can ask also for Danvers, and then we take the two questions together. Now, Danvers is saying that that's a very good presentation, I believe, from Teresia, and he's asking that you said 10 days post-positive test, negative or positive or negative. So how can we elaborate on the discharge care pathway for symptomatic case, since you said 10 days post-COVID tests or negative? So that one is Danvers, Mildred. And then there's another interesting one also here, similarly to the same. This was Eunice. Eunice is asking that for those with immunosuppression, especially for antenatal mothers who test positive for COVID, how would we then, and then the HIV exposed baby after delivery, is there any special care for the baby who is born from immunosuppressed mother attending antenatal clinic, and the baby is now within that scenario? So is there special attention given to that baby? So let's start with the home-based care African setting. Is it possible? Can we do it? And then asymptomatic cases, and then the tricky one for antenatal mothers, especially with HIV immunosuppression. Yes. So let's start with Teresia, and then we take it open. Yes.
Thank you, Ken. The home-based care. I think I might have had the CS talking about that the ministry has been grappling with the idea that they need to start rolling out on home-based care. However, our situation in our African setting, and just to come back to us, Kenya, it's a bit tricky. Let's talk about an area like our slums, maybe Kibera, and we know Nairobi has over 1,000 cases. And we have Kibera, Liti, and maybe other settlements. And those are the places where we have maybe 7 or 8 people living together. We could be even having a single parent with 7 children who will need, if the mother is infected, then what happens to the 7 children who are in that house? How does she even social distance? And even things as basic as hand washing are a critical thing. Things even to do even with having washrooms is a critical thing. So it's something that we will have to take in as people and synthesize and see who can actually implement these home-based and who cannot, and who can may be able to take up the measures, and who may not be able to implement completely because of their setting. I think that then should be isolated from the community and taken again to the treatment site and all that. So it's a bit tricky. Just the way Africa is also different, and total lockdown has not worked. Even the restriction of movement is not working because we work from hand to mouth. So those are the realities.
So so we are saying that Africa needs a different type of approach. So if something has happened in Europe, it might not really necessarily happen in Africa, because lockdown has not helped Africa, right? And maybe it has to some extent. Uganda, for example, was the first to close, but they still have cases of COVID, even with health workers. So where did they get them from? And there were no planes coming in. There are no trucks moving inside to Uganda. But you find they're still affected by COVID. So it is a tricky one, yes. But I've seen there's a guideline on home care that has been issued. And CS has mentioned that those who have COVID and are asymptomatic, then will be released to go and get home-based care. So that is a tricky one, but yes, let's hear from the other panelists. Yes. Maureen, how are you?
Hi, Ken, how are you?
I'm blessed, yes.
All right, there's something about
home-based care, Africa.
I wanted to mention. We have very strong home-based care, as Ken has rightly put it in the question and answer section, for other diseases. It would be much easier if we had to go to home-based care, because there's a reason why they're going to home-based care. Our healthcare system, our health facilities cannot handle the number of patients. Now, instead of creating parallel home-based care for COVID-19, how about leveraging and training already existing home-based cares at county level through whichever organizations they're doing, because these are experienced in IPC guidelines. So it's much easier to train already home-based care providers that are in existence so that they support the COVID-19 response. It is very tricky, as Teresia has put it. There'll be questions around PPE, because PPE is a big issue. If you're gonna send home-based care providers out there, it's going to be a big issue. However, starting parallel programs for COVID-19 on home-based care may not be cost-effective, may not work at a rural level. Using existing programs may be a better strategy than starting afresh. That's my opinion on that.
Thank you. We also have the one from Danvers. We have the question of immunosuppression, mothers who are seeking antenatal services in a COVID environment. So how do you attend to the baby? That is a question from Onchiri. Any special consideration to the mother and the baby? Already they have an immune suppression. And now there's COVID. Yes.
What I know, WHO has limited studies on HIV and COVID. And the bottom line is that with HIV, and especially if somebody is not on medication or they have a low CD4 count, then they are prone to severe disease. Okay. And what we would advise them is that they need to be able to address this comorbidity, at least ensure that they are on treatment and their CD4 count goes up. And of course, all the IPC measures should be put in place. And there are a group of people who need to be able to take care of themselves better and even be more extra careful, even on their movement, ensure that they don't need to go to the clinic unnecessarily. They can be able to just call and ensure that they get their medication also refilled for a longer period, if necessary, maybe for more than 1 month. If they could be having even tuberculosis, these are things that they need to be treated on. But they really need to take care of themselves well. The only thing that we know is that they are prone to severe disease. Yes, Ken.
Thank you. Now, maybe to give another last one before I give back to Walter. The country has, Kenya has more asymptomatic cases because we are not experiencing COVID as the European countries were. So yes, there's COVID in Kenya, but we cannot see the symptoms. We cannot feel it, right? That is not to say that there's no COVID, there is. So how would we then, going back to what the CS has mentioned today in the afternoon, that those in the isolation and quarantine centers will be released to go and manage themselves. So is it possible for us, as we've mentioned here, and I love what Emily has mentioned, that we do need to have a quality improvement process, right? So that even if the government facilities are full, as mentioned by the CS, the private sector then can pick up those cases and be able to take them through treatment and case management. Is that possible, or we just allow them to go home?
Ken, I think there's something that we need to realize here, that the treatment for COVID-19 is quite expensive. And sometimes back the PS actually said that this is one of the most expensive disease, and gave a rough figure of two weeks treatment to be around 800,000 Kenya shillings. And that's why even the insurance are not even taking up this. They're not burdened on this pandemic because it's very expensive. And I think even the private sector might be getting scared of taking up COVID treatment. I think that would be a nice and interesting discussion to see how they go forward on it. But again, releasing everybody from the isolation centers and the quarantine centers to go home and self-manage is a disaster. I think we've not even yet seen the full-blown experience of this disease. We are just 3 months down the line. We don't know what awaits us. We have our elderly who have been safeguarded in the up country, in those counties where we know our demography is the aged up country. So when we open up to everybody, we are not sure of what we are waiting for. So it's very scary. As healthcare providers, we need to be able to advise the government and the policy makers. Yes, Ken.
Now, I'm just thinking like a layman here. It is expensive, as Maureen has mentioned, because of the PPEs, right? And if you hear most of the patients say they've only taken our samples, they're yet to come back to us. So what makes it expensive is the PPEs, because the PPEs are expensive. So if they are let to go home, that means that they're not sick. The medications, the vaccine are still not yet there. The medication they're being given is normal medication that we've been using in Africa for the longest time ever, which India is working on, which Israel is working on, which our neighbor Uganda is working on. So the most expensive part here could be the PPEs. So if we are able then as a country to see that, yes, we can manage, leaving them to go home is just a disaster in itself. So in as much as it is expensive, then how else can we, using our quality improvement methods in our health facility, safeguard one, the health worker, 2, the patient, 3, the family. We are using quality improvement, right?
Yes.
And we are saying there's no PPEs at home. But at home, how will they heal then without medication?
Can I chip in, Ken?
Yes, Walter.
Thank you, panelists, for the very, very nice discussion. I would say that home-based care is the next front. And in terms of who does what, every county, actually from the discussion, will be planning their own home-based care approach, meaning health workers in the counties will be able to plan on their own using the conditional grant that they have been given. They will be able to have homegrown solutions. So whatever can be done in the slums, for example, in Nairobi, may not be the same in the rural areas. In fact, some places would be less congested. It could be an opportunity to actually grow the community strategy. So we have all families listed and you know who is where. So in my thinking is home-based care would be our next discussion so that we look at, is really home-based care practical? To me, having looked at MOH guidelines and all that, it is possible. The only thing is that we need to establish the structure. So what I would say is we as health workers must go out of our comfort of staying in facilities and actually establishing systems in our catchment areas to be able to participate in supporting home-based care, because the rapid response team from each county shall actually decentralize to sub-county up to facility level catchment where they have a team visiting homes so that they are assessing and saying, is this home fit for home-based care? If the answer is yes, then they will be able, and there are requirements. For example, they need a specific room for the clients, for the patient, and they need to know how to assess and even be assisting the patient while at home. However, they will be doing self-assessment and reporting on a daily basis, doing the vital signs, is there breathing problems, is the temperature going up, all that. It needs a robust system. So what I would recommend is, yes, let us be bold and go to the next level. Thank God so far we've not had very serious cases, and therefore we may not need really see the overwhelming numbers as they are in the West. So I would say let's do that in the next webinar and see how we can go about. Otherwise, it is going to be practical when health workers go out of their comfort zone and start working in the community.
Thank you. Thank you very much, Walter. Maureen, Emily, Teresia, and okay, I'm seeing 2 Maureen's. Yes. So now to wind us up, let's get a parting shot. But the country is going to open. The president has mentioned that more than once that we are not going to remain in a lockdown for a long time. No, people need to go back to work. Yes, and as they go back to work, we are not saying that COVID is being dealt with. It is there in the community. So how then do we open up the country and focus on home-based care? And again, the health worker is trained in the facility here. If the country is open, the hospital the numbers will fill up, because everybody is now not going to the hospital because of COVID. But once we tell them that now you can come to the facilities, the numbers will definitely go up. So we have to understand, yes, that home-based care must be looked into very, very thoroughly, and we see how best we can manage COVID. So as we now wrap it up, thank you very much, able panelists and participants. I will start with Maureen Kinoti to give us the parting shot for today, and then we move to Emilio, Mary, Teresia, then hand over back to Walter. So Maureen.
My parting shot is on sharpen your clinical skills for those of you who are with the patients, because when you're moving to the phase of home-based care, again, you're the person who will be telling the clients the danger signs. So remember all that, and remember to take care of yourself. Safety first, as Teresia has emphasized for quite some time now. Thank you, and have a good evening.
Thank you, Maureen. Yes, Emily.
Oh, my parting shot will be to emphasize to every facility that as we move to home-based care, we are the core leaders to ensure quality is implemented even in the home-based care. So as we move forward, let's ensure like we have protocols on everything. Let's ensure like we have systems in place that ensure everybody is safe from home to the facility itself. Whichever movement we are doing, let's ensure that we are implementing protocols properly. Thank you and have a nice evening.
Thank you very much, Emily Omari. Teresia Mumo.
Yes, Ken. My parting shot would be to highlight that as we anticipate opening up, then our curve will still go up, because this one has been demonstrated in other countries, and we may not be very unique about it. So clinicians and everybody needs to sharpen their skills in terms of tracking patients, being able to treat them, being able to triage them, put them in the right care. Maureen talked about of early therapy, early supportive therapy. We need to be able to know what oxygen to give, how much to give, what empirical antibiotics to use. So these are things that you need to be able to have them at our fingertips. And just to say that the average length of stay of a patient in the treatment center is around 2 weeks. So everything has been filled up. So we might have these patients at our doorsteps, and you will have patients and know where to take them to. So let's start knowing how to manage these patients as we get to know the next stage. And thank you, Walter, for suggesting that we need to talk about home-based care. I think that is something that we need to look forward to and explore, because that looks like the next move for all of us. Thank you so much.
Thank you, Teresia. Walter, parting shot. People are not going to the facilities and we are going home-based care.
Wow, thank you, Ken. I will appreciate everyone for having come for this webinar. And now the next step is that we have an opportunity. Home-based care is the way to go. Many parts of the world have managed because they're able to attend to clients who are not very sick, and therefore they're able to manage at home. Next steps, we'll say that let's look at how we can be able to respond to home-based care as an approach, because we need to prepare to guide our clients and families and even relatives to be able to handle and support the clients who are stable at home and not to spread the virus to the rest of the family. Having taken that, because many of the participants are saying, let's take that as a next discussion, we'll consider that. However, tomorrow, going forward, we have another set of 4 to remaining so that we are completing this set. Tomorrow we'll be doing, going forward, we'll be doing experience sharing, and we'll be bringing on board various facilities, frontline soldiers who have boldly stood in the fight of COVID. And to start that off tomorrow is Jumuiya ya County Sapwani. You may be aware, as Mombasa is rising up, Kilifi is controlling. So what is unique in Kilifi? We are watching their numbers. They are not increasing as much. So what is this magic bullet that they have come up with? That is the thinking we are looking at. So tomorrow, Jumuiya County Sapwani will be leading us, and we will have experience sharing from Kilifi, and also we'll be expecting to reach to you as panelists, participants. If you have something to share with us, we will be able to pick from there, and we'll be able to incorporate you in this journey together. Let's be bold and strong. So up to next time, see you everyone. Is there anything, Ken?
Thank you very much, our able panelists, Maureen, Teresia, Emily, Kibet, and myself, Ken Auma. Until tomorrow, thank you very much. So let's meet tomorrow from 6 to 7 p.m. God bless you and keep safe.